So thank you for that introduction. I'm Leslie Lappalainen. I am delighted to chat with you today about alcohol withdrawal management for this BC ECHO session. So a couple of acknowledgements to start. So this material is made possible through a financial contribution from Health Canada and the GPSC, a partnership of Government of BC as well as Doctors of BC. And the views expressed herein do not necessarily represent the views of Health Canada or the GPSC. So as Nicole had said, I'm one of the medical leads for addiction medicine for Interior Health, and I work clinically as an addictions consultant at Kelowna General Hospital. And in terms of disclosures, I just want to disclose that my partner does own and operate a craft alcohol business, but I don't anticipate that this conflict of interest will impact my approach to alcohol use disorder care. And all of the material that I'm going to be discussing with you today is part of the BC CSU guidelines. In terms of commercial support for this ECHO session, the BC ECHO on substance use for alcohol use disorder has received financial support from the GPSC and in-kind support from the BC CSU for logistical support. And then I have received an honorarium for preparing content and presenting today. All of the content as part of this ECHO series was reviewed for potential bias and validated by members of an independent scientific planning committee and also approved for accreditation submission. So we have some pretty lofty objectives for today. So by the end of the session, I'm going to kind of try and move through this material fairly rapidly, and there'll be hopefully some time for questions at the end. So we'll talk about alcohol withdrawal and the mechanism of action, or kind of the pathophysiology as to why this is happening. And then we're going to spend some time talking about the PAUSE, which stands for the Prediction of Alcohol Withdrawal Severity Scale. And it's essentially a tool to assess an individual's baseline risk for complications of severe alcohol withdrawal, namely alcohol withdrawal seizures and delirium tremens. And then we're going to talk about withdrawal management strategies based on a patient's risk of those complications. And then we'll spend a little bit of time at the end talking about kind of unique considerations for more rural and remote communities. So this is really just an overview of the continuum of care for alcohol use disorder. And throughout these ECHO sessions on alcohol use disorder, we'll be kind of working our way through this diagram. So initially talking about screening and intervention for individuals who meet the criteria for high-risk drinking or at-risk drinking, but don't meet the criteria for alcohol use disorder. Doing brief intervention with them. And then for individuals that meet the criteria for an alcohol use disorder, you kind of work your way down to where it says PAUSE there. So again, that stands for Prediction of Alcohol Withdrawal Severity Scale. And this is essentially a way that we can triage patients as to who is low risk of serious alcohol withdrawal and who is at higher risk of serious alcohol withdrawal. And based on that, combined with kind of their medical history, as well as incorporating what we know of their social circumstances, we can determine who's most appropriate for outpatient withdrawal management and who really needs inpatient withdrawal management. So that's going to be the focus of our session today. And then the last bit of kind of this curve is the continuing care. So alcohol withdrawal alone isn't treatment for alcohol use disorder. It's really just treating their acute withdrawal. And when I see people in hospital, I always talk to them about the fact that part of what I'm doing is managing their withdrawal, but the more important work is what we do when they leave hospital, or if we manage their withdrawal at home, what do we do afterwards to support them in that? So future ECHO sessions are going to focus on that, talking about pharmacotherapies for relapse prevention, as well as psychosocial supports and community supports. So what is alcohol withdrawal? Essentially, to understand this, you need to know how alcohol acts on the brain. So there's really two main neurotransmitters that we're going to talk about. And this is the only slide that the whole talk isn't going to be about this, but two main neurotransmitters. There's GABA, which is neuroinhibitory, and glutamate, which is neuroexcitatory. So essentially, when alcohol acts on the brain, it is a GABA agonist, so it causes neuroinhibition, and it's a glutamate antagonist, so it suppresses the excitatory effects. What happens is, if with chronic alcohol use, your brain always wants to try and maintain homeostasis. And so what ends up happening with chronic alcohol use is that you end up down regulating your GABA receptors and you up regulate your glutamate receptors. When an individual has those kind of brain changes that occur over time and they abruptly stop drinking or significantly reduce their alcohol use, you get this relative imbalance of glutamate and GABA. And you can, in a fairly simplistic way, you can think of alcohol withdrawal as being a state of excess glutamate or neuroexcitation. And so a lot of the withdrawal symptoms that we see with alcohol withdrawal, you can again think of kind of neuroexcitation. So autonomic hyperactivity, so increased heart rate, they often have an increased blood pressure, they're diaphoretic or sweating, insomnia, increased hand tremor, nausea, vomiting. They can have hallucinations, and these can be visual, auditory, or tactile, agitation, anxiety, and then what we kind of want to prevent is things like generalized tonic-clonic seizures, as well as delirium tremens. And so to officially diagnose alcohol withdrawal, you have two or more of these symptoms that occur within several hours. And there's symptoms that are not better kind of attributed to other concurrent medical or psychiatric diagnoses. And so sometimes this can get complicated when someone's admitted to hospital and they may have nausea or vomiting secondary to another medical condition. So if we have time, we can talk a bit more about kind of more complicated alcohol withdrawal in the context of concurrent medical conditions. The symptoms of alcohol withdrawal generally start within 6 to 24 hours after the last drink and peak within 2 to 3 days and generally resolve between 5 to 7 days. About 50% of individuals with long-term alcohol consumption will experience withdrawal symptoms. And of these, 10% can experience severe withdrawal symptoms. And the two things that we really use to define really severe withdrawal symptoms are generalized tonic-clonic seizures or delirium tremens. And an important note about both of these is when you're asking questions to patients around alcohol withdrawal, and they say like, oh yeah, I had DTs. Ask them what that means, because sometimes their definition of delirium tremens and our definitions are quite different. And so sometimes I'll ask patients like, oh, have you ever had delirium tremens? And they're like, oh yeah, I was really shaky. And that's their definition. So it's really important that you kind of probe as to what symptoms they actually had. Delirium tremens itself is fairly rare. It's maybe 3 to 5% of hospitalized patients, but it can be very severe, and often people need a high level of care like ICU care. And so what it's characterized as severe is characterized by is severe confusion, disorientation, hallucinations, along with severe autonomic hyperactivity. So we see increased heart rate, blood pressure, and often increased temperature. So assessing the risk of severe complications of withdrawal is important, such that we can determine kind of who is high and low risk of severe complications. And so we'll talk about the pause tool that we use for this. And I think it's important to know that the pause is one part of their assessment, but we also need to incorporate what their medical history is, as well as their social circumstances. So if they're housed or not, if they have support people around them, as well as patient preferences. So the pause I've talked a couple of times about so far. So it stands for Prediction of Alcohol Withdrawal Severity Scale, and it's a tool to estimate the risk of severe withdrawal. It is in the BCCSU guidelines and is available in these slides. I do have a slide on it, but we won't spend a ton of time kind of reviewing all the criteria just because there's a lot of material to cover. But essentially, if someone's pause score is 3 or less than 4, they're low risk of severe complications of withdrawal. And if their score is 4 or higher, they're at an increased risk of severe complications of withdrawal. So this is what the pause tool looks like. Again, I would encourage you to kind of look at it in the BCCSU guidelines and even print it out or have it in your office for reference. So alcohol withdrawal management can look like a number of things. So supportive care, symptom management, as well as pharmacotherapies. And again, as I mentioned earlier on that slide around the continuum of care for alcohol withdrawal, withdrawal management alone is not treatment for alcohol use disorder. And so we need to think about what do we do after we manage someone's withdrawal. So looking at prescribing pharmacotherapies for relapse prevention, doing referrals for substance use, like outpatient psychosocial treatments, as well as community supports. So again, for individuals that are low risk of severe alcohol withdrawal, they can generally be managed as an outpatient. And if pharmacotherapies are necessary, we can look at using non-benzodiazepine medications. And then for individuals that are high risk, so a pause should have 2 S's there, I apologize, a score of 4 or higher, they generally should be managed as an inpatient. And we would use benzodiazepines as there's good evidence to support their use for preventing seizures and delirium tremens. So first, we're going to talk about outpatient management. So outpatient care consists of medically supervised withdrawal management in an outpatient setting. So this could be in primary care settings or outpatient addictions treatment. And it's safe and effective for the majority of low-risk patients and more cost-effective than inpatient care and can be less disruptive for patients. So things to consider if you're thinking about outpatient care for a patient is really their ability to follow up. So generally, we would like to arrange follow-up for these patients for the first 3 to 5 days of their withdrawal process. And this doesn't necessarily have to be in-person visits in a primary care setting. It could be telephone or video call follow-up, but you should be able to follow them regularly. And then the other things we want to think about are community referrals to community supports, and then just that frequent reassessment. Other considerations before kind of arranging outpatient care are absence of potential contraindications. So really these are severe kind of medical conditions or severe psychiatric conditions, which may preclude safe outpatient management. So acute confusion or cognitive impairment, acute illness or infection that would require inpatient management, severe co-occurring substance use or pregnancy. So all of these individuals should probably, if they had these conditions, should be offered admission. Ability to take oral medication. So if they have significant nausea, vomiting, for example, and they're unable to tolerate PO, they should probably be admitted. And again, that ability to follow up. And then the second to last point here is around having a reliable family member or friend that can check in on the person. And I think this is really key for safety, to ensure that there's someone that's able to check in on this person regularly and make sure that they're safe. And if things aren't going well, that person could bring your patient into care to see you in primary care and or to the emergency room setting if needed. So all outpatients should be assessed for the need for pharmacotherapies for managing withdrawal. And again, if pharmacotherapies are needed, we'll look at non-benzodiazepine options. So the main options that are included in the BCCSU guidelines are carbamazepine, gabapentin, or clonidine. And I have a couple of slides here with protocols, but I would encourage you to look through the protocols in the BCCSU guidelines. So in the interest of time, because we've got a lot to cover, I'm not going to cover these in detail, but main things with carbamazepine are the contraindications are significant hepatic disease, bone marrow suppression, severe hematologic disorders, or AV block. Gabapentin is another option for outpatient withdrawal protocols, and you'll have these slides to reference later on. So we're going to jump into inpatient care. So for individuals that have a PAUSE of 4 or greater, generally we want to offer medical monitoring for these patients. So that could be at a dedicated withdrawal management facility, or detox, or at a hospital. And generally for these patients, we're going to use benzodiazepines. And again, the reason for using benzodiazepines is that they have good evidence to support their use for decreasing severe complications of withdrawal, including seizures or delirium tremens. Regardless of the PAUSE score, so even if their PAUSE was 3, there are other conditions that may make you kind of decide to admit someone to hospital. So if they've had unsuccessful attempts at outpatient withdrawal management in the past, or you've started outpatient management, but they're not responding to the medications that you've been giving them within 24 to 48 hours, they have unstable medical conditions, psychiatric disorders, concurrent use of CNS depressants, severe liver disease, pregnancy, they should be offered admission, or they don't have a safe place to do it. So they don't have stable housing, or they don't have a safe person that can help with kind of monitoring and dispensing the medication. So in all of those situations, we should be looking at inpatient care. For inpatient withdrawal management, often in hospital and in withdrawal management facilities, will use a CWA, which is essentially a protocol whereby it's symptom triggered. So the patient will receive points for various parameters for alcohol withdrawal, and depending on the number of points that they get, a benzodiazepine is dosed, and then they're reassessed at a regular interval. So this is called symptom triggered approach. And there's other approaches. So there's a fixed dose approach, which there's a protocol here for. Generally, the CWA is used because overall, people require fewer benzodiazepines with a symptom triggered approach as opposed to a fixed dose approach. So considerations for kind of rural communities. So we know that not every, like I work in the interior, so there's many communities that don't have access to an inpatient withdrawal management unit or a detox unit. So in some communities, they do have kind of home withdrawal programs. In other communities, they have like a detox program, so intensive outpatient programs. And if an individual has kind of a reliable friend or family member that can be involved in monitoring, you can consider kind of benzodiazepines to be given at home, but you really need close reassessment. And in someone with a really significant history that's had multiple seizures from withdrawal before, delirium tremens, really we should be advocating for kind of hospital admission for those patients, or travel to a withdrawal management unit. So in summary, alcohol withdrawal is a result of kind of neurochemical changes as a result of chronic alcohol use. And again, the main two neurotransmitters are GABA and glutamate, and the pharmacotherapies that we use act on those receptors. The PAWS, so prediction of alcohol withdrawal severity scale, can be used to assess a patient's risk for severe complications of alcohol withdrawal. And then withdrawal management pathways should be tailored to a patient's risk of severe complications from withdrawal with distinct pathways based on their level of risk. And then patients in communities with lack of inpatient withdrawal management services can be closely monitored through community-based care. And just as a reminder, there is a 24/7 addictions medicine line. So you can call in, seek advice, and physicians, nurse practitioners, nurses, midwives, pharmacists can all call this number. And then also just a shout out for other learning opportunities through the BCCSU. So this Echo session is part of a kind of series of learning opportunities available, including the BCCSU conference, which is coming up in a couple of weeks from now. So I'd encourage you to sign up for that. And here's some references. And we may have like 2 minutes for questions.